Hi everyone. Thanks for joining me, Jesse Awanas at jessephysio.com on today's podcast. Today we'll be interviewing Dr. Greg Lehman, and I want to give you a brief biography on who he is. So Greg started his career path by receiving a natural science engineering scholarship that permitted him to train with Professor Stuart McGill in his occupational biomechanics lab, subsequently publishing more than 20 peer-reviewed papers in the manual therapy and exercise biomechanics field. He then went on to graduate from the Canadian Memorial Chiropractic College in Toronto as a Doctor of Chiropractic, and then was an assistant professor at the college, teaching a graduate level course in spine biomechanics, instrumentation, as well as conducting more than 20 research experiments, while also supervising more than 50 students at the school. If that wasn't enough, he then did a Master's of Science in Physiotherapy from Queen's University, graduating alongside myself, ironically, in 2010. Greg has lectured reconciling treatment biomechanics with pain science, running injuries, and golf biomechanics, occupational low back injuries, and therapeutic neuroscience. I want to welcome to the program today Dr. Greg Lehman.
Thanks, Jesse. Good to talk to you.
Great. Thanks for doing this. I really appreciate it.
I
know you're a busy guy. You're flying all over the world these days and doing a lot of great stuff.
Yep.
You just
I'm not in the cockpit.
Sit there and talk. No, yeah. But, okay. So we're going to get started by asking questions that I'm sure a lot of people I see in social media want to know about. It seems like every time you post something, a research review or critique, there's a million and one but this and but that, and how about this, and how do I integrate that into their own practice. And a lot of people I find that because of what you're bringing to the forefront of the knowledge base here, you're basically making research kind of fun again by making a fun and humorous spin to it. And a lot of people are kind of thinking more about that stuff that you're talking about, but they don't always know exactly what it means or how they can best use it in their own practice. So my hope today, people have a better understanding of not just what your theories are and thoughts are on a bunch of topics, but how they can integrate some of these thoughts into their clinical practice. Okay?
Let's do it.
All right. So my first question today for you relates to kind of a popular model that has been getting a little bigger over the past few years. So I wanted to get your take on why you think such theories as the integrated systems model or the thoracic ring model has taken off. And do you see explanations for pain as these explanations talking about ring shifts going one way or the other, creating all kinds of problems from knee pain to hip issues, so on and so forth? Do you think being diagnosed with a ring shift, as an example, as being positive, negative, or detrimental to a patient's outcomes?
Okay, so I think there's a couple questions in there. But so the integrated systems model, it's certainly more than just the ring shifts or the thorax, right? It's
right.
What they do well. To me, really, it's just the biopsychosocial approach. Diane Lee and L.J. Lee wanted to address everything in the person. They look at all the factors that can influence pain. So it's a bit unfair just to say it's about the biomechanics and the thorax. It's just that's probably where the more contentious things lie. I don't know why they had. They probably just had to call it something else for marketing. But then when you peel it back to the biomechanics, really, and I remember you wrote about this in one of your blog posts years ago. To me, it's kind of old school chiropractic. It's looking at how every joint functions and moves, and there's an assumption that there's an ideal or an optimal. And when you deviate from that ideal or optimal, the body is likely to have a problem somewhere in that kinetic or kinematic chain, right? It's regional interdependence really run amok, meaning your foot pronates, or they call it, a lack of load transfer or form or force closure, and that will lead to some dysfunction right up to the SI joint or the thorax, or vice versa. If the thorax or a rib is shifted or a muscle is pulling on it and it's tight and it doesn't have some whatever proper is alignment, that could cause a problem down in the foot, in the knee, in the hip, or the SI joint. So that's a crude take on the model, but that sort of seems to be what it is. And then what they do really well is they talk about a meaningful task, which I love, is they say, what does the person want to do? What are they having trouble with? And then let's find the sort of driver of what they're having trouble with. But that seems to boil back down to either altered arthrokinematics, so there's something wrong with a joint, and then there's something wrong with the function around that joint that's leading to that problem. So
Yeah,
does that sound fair? I don't want to misrepresent the model.
no, I understand completely that they look at, but my understanding, I was listening to both of Diane and LJ Lee talk about it, both at IFOM in Quebec City 4 years ago, and then at an orthopedic division conference, I think last year, a year before that.
Yeah.
One of the things that I questioned actually Diane Lee in person about was she had showed a video at IFOM of a rower who had, I believe, really bad knee pain, as in, like, with any time did the rowing motion, like the bending forward, flexion of the knee, really hurt. And then we talked about, as a group, what's the meaningful task, all the other psychosocial components, the being afraid of the pain, which is all very evidence-informed stuff. But ultimately, what happened was she said there was a fourth or fifth ring shift, and she showed a video of herself putting her hands on the thorax and pushing one way this way, one way the other way, and then while holding those rings in place, having the patient go back and forth into the rowing motion, and the patient was absolved of their pain, and then everyone clapped and thought it was amazing. And so the explanation, I think, is spot on as terms of how to look at pain as a kind of a multitude of factors, but ultimately how you quote unquote fix that pain lies in biomechanics, from what I understand to be true anyways.
Yeah, in that person, that they would say so. So I guess that's where it gets contentious, right? And that's where it's just old school chiropractic, that you find some funny joint movement and you correct it, and then it corrects the whole chain. And that's where we have and that's why, to me, it's the biomechanics that challenges the biomechanics, because that assumes that you can palpate something that's dysfunctional, that you have that ability to feel it, and then that it's reliable, and then it assumes that it's valid, that dysfunction is truly a dysfunction and causing it, and then that correcting it. I don't doubt that trying to change it might change the pain sometimes, but it doesn't mean it's for that reason, and so. Yeah. You could do a number of different things there as well. And so you asked about why therapists like that. I mean, speaking from personal experiences and when I went to the chiropractic, that's a powerful feeling or idea that you find the true cause of the problem. I remember saying that on my interview to chiropractic. That's why I love the idea. You find the true cause, which would be a malposition of a joint in chiroland, and then you fix it, right? That's so lovely. That's the whole idea, that you have these magical hands, and you can look at someone with their dysfunction and say, "Oh, I can fix you," and you go in and do it, and boom, they feel better right away. And I think people are drawn to that, and so they want to use their hands. So it's really nice. It's easier and simpler than doing other things that go into the murky world of the biopsychosocial approach, which is tougher. But at the same time, that other approach is often a lot simpler. Where if I had someone that had knee pain rowing, sometimes I just say, well, knee pain is just knee pain. And you look at, why is that person having trouble rowing? Like, what else is going on in their life? Did they increase their load too much? Do they have to do a subtle change in technique just to let it desensitize and then build back up? But that's really, really simple. And then it's harder to sell simple sometimes.
I agree. I know a quick little anecdote. When I was going through physiotherapy school, as you know, I was one of those people that really liked the orthopedic stuff. I was still in that model of, I want to be able to fix the world. I want to assess stiff joints, mobilize this, manip that, pull this, push that, make people feel better. And so that kind of led me going down the orthopedic division route to become an FCAMT. And I'm telling you, it was not very popular towards the end on those courses once I started kind of questioning what I was being taught. And a lot of times we'd be in these groups of 30 to 40 physiotherapists, and I just my jaw would be dropped to the floor at times that people were talking about assessing rib rotations. And this is the funny thing: you learn about these theoretical biomechanics in our orthopedic division manuals, and for any of the physios listening, you'll know this. it says if you're looking at the biomechanics of the ribs and the thorax, it's all theoretical in nature, meaning we're not exactly sure this happens, but this is what we think happens. And then when we say we, it's all credited to Diane Lee's books, and she basically summarized that with like right rotation, the right rib rotates posteriorly, left rib anteriorly, so on and so forth. And then not only are these biomechanical movements theoretical, we're then supposed to palpate them and make a diagnosis off them, and then say this is why this person has pain. Even without knowing the research, I was still like, what? How are we going to correlate what we think we feel, which we know is shitty anyways, and then say, oh, the reason you have whatever problem you may have is because of a restriction of your rib posterior roll on the right, which is something we don't even feel and even know happens with right rotation to begin with. So I really got not in trouble, but I questioned a lot of what I was being taught going through the system.
It's odd that it's taught. I mean, these are notions. They're not even hypotheses and not theories. It's just a notion that someone has. And lots of us have lots of notions. But somehow they are such a popular force that it gets into a curriculum. You know, it's just a notion like a stone healing and energy crystals. You know, maybe not quite as bad, but these are just ideas that people have. And it's okay to have ideas, but they should be on the fringes. They shouldn't be the foundation of the most advanced manual therapy that you can take in Canada. And that's sort of what I object to. Anyways, we should talk about something else. Your podcast.
We'll move on. So with that said, do you see a role for manual therapy in the treatment of pain?
Totally. I mean, you look at most studies that compare exercise, which is my go-to, and then you have exercise plus manual therapy, and it usually does a little bit better. I mean, the effect sizes aren't massive, but still, there's a huge number of people that get help when you put your hands on them. And yes, we don't know the mechanism why, and that's okay sometimes. Just because you don't know the mechanism doesn't mean you stop doing it. It's the same thing with the rib approach. You know, it's just saying that you know the mechanism that's the problem, and saying with utmost certainty and brooking no dissent. So it's okay to do things because it helps people, as long as it's not harming them.
So it's just the language we're using, I guess, as more so than the intervention, is what you're saying.
The language could be the problem. The intervention is the problem if you're not doing other things that have better evidence, though. That's where it's a problem as well.
I was going along with the same topic. I was on Facebook talking to a bunch of people, most of which I know you know, regarding manual therapy and incorporating that into a pain science kind of model. And there were a few people that I was kind of shocked when they were arguing with me, saying that the second we put our hands on somebody, they become dependent on us, even if it's subconsciously, for their pain relief. Do you think that by simply
the second anyone comes to see you, that there's a bit of a dependency there, right? Because of course they have some dependence. Otherwise, they would have fixed it on them by themselves.
Exactly.
There's always a risk. My personal rule is, if someone's gone to see someone and they have a persistent pain for more than 3, 4, 6 months, and they've seen great manual therapists that have done 3 different techniques, I'm not going to be the one that has the arrogance to say, well, now they just need my hands. I have the right manual therapy technique for them because I'm better than these other people. So when it comes, and you can still do it if that's part of your shtick, but when I see those people, then I tend to use a lot less manual therapy, and I say, we have to try something differently. And manual therapy typically should just be a small part of your therapy anyway. You know, it's multidimensional pain, so we have multi-skilled therapists doing multiple interventions.
Exactly. I think it's the problem when you have a patient coming in week after week and all they are is lying on a table being passive, getting mob, manipped, acute, whatever. That's the problem, because they can't integrate that into a meaningful approach, and they can't see any benefit. Oftentimes, I use manual therapy as a way of what I call facilitating the calming down of the nervous system. So I will do whatever intervention I deem necessary, hands-on. Well, I'll test something like a squat and say it hurts. I'll do X, Y, and Z intervention, and then I'll retest their squat. And if it's better, then we can say that. And then as long as my theory is, as long as I preface what I'm going to say by explaining by explaining that manual therapy didn't really change anything in terms of joint position or tight muscles. All it did was allow the nervous system to kind of calm down, and if you do the following exercises, you can achieve that on your own without my assistance. And I think as long as we frame it that way, without telling the patient, you must come back to see me because I have the skill that you need, I think we're just fine using our hands to help people feel better.
Sounds good.
Sounds good? Okay. So last week I interviewed Dr. Stuart McGill, and I asked him his thoughts on the correlation between and he was very gracious to answer my questions, by the way. He was very nice.
Superstar. Yeah, of course he is.
Yeah. Very very humble and open to
always
answering.
Been like that. Yeah.
Yeah, it's fantastic. So I asked him his thoughts on the correlation between things like job satisfaction or locus of control and back pain, because there's evidence that shows that those who hate their job and feel they have an external locus of control tend to suffer from more chronic back pain. When I asked him about the correlation between those two findings, he responded by saying that the evidence we have does not really show a cause and effect, and that there always has to be an increased load placed on the spine for first-time back pain to occur. Do you agree that all low back pain...
Did he say low back pain or low back injury?
Injury. Sorry. Oh, yeah. See, that's a good distinction. Yeah. Do you agree that all back pain, injury, is initiated by changes in load that create failure or damage to structures in the back?
No. I don't. I mean, I would totally agree with Stu when it comes to low back injury, that load and all of these variables is a big problem, because you're talking about tissue disruption, and the tissue fails to respond to the applied loads. I mean, that's an injury. But pain is a different thing. And that's well established, that pain isn't well correlated to damage or degeneration in the spine. Pain itself, if you look at the vitamin and Bachier twin studies, isn't well correlated, isn't often correlated with the amount of stress on the system. I mean, you can have people who have a back pain flare-up, and they're relatively sedentary, and you link it back to some other psychosocial driver in their life. This happens all the time. You know, there's or someone has a lot of back pain, they go on vacation and they're even more active and stressing their body, and they have less pain because other things have changed. So if we're dealing with pain, I wouldn't agree with the statement. If we're dealing with injury, then I would agree more with the statement. If it comes to pain, I don't think load is a sufficient condition, too much load. If it comes to injury, then load certainly is a factor, because you're maybe dealing with damage there. But we can't say that we have any causation. We can't put load as a cause. Our studies aren't designed to do that. Most of them are correlational, even if they're prospective. It's really hard to infer causation. When they do the prospective twin studies, if you just look at, so they'll study two twins and their occupational loading, or their loading through sports through their life. So they have the same genetic components, which is a big driver of degeneration. Those that have more load on their spine often don't have more degeneration. So that's always quite interesting. But some of the other studies will say those that have a higher physically demanding job, so higher physical loads, they might have slightly more pain. So that's interesting. So that it's as confusing as that. So the body responds well to the load, and that it doesn't degenerate, but then some subgroup will have more pain in different studies. And it doesn't mean that they have more pain because there's more damage. It's as confusing as that. Okay. You know, because it's like Tim Gabbett's work in sports. So athletes can have high loads and they don't get injured as long as they've adapted to them. But when they end up getting injured is when they go from a low chronic workload to a high acute workload. You know, it's that big change in the load, but it's not the total amount of load that's the problem. It's the change. And you can look at the same thing with psychosocial stressors. You know, you can handle lots of psychosocial stress if you're used to it, but someone who's not, that might be enough to cause a threshold to be reached, and then they suddenly have pain. But as for correlation or drawing a causation of why someone gets low back pain, no one can say that. It's that confusing.
So again, yeah, we can't draw inference because of even obviously a lot of people that listen to this know that the correlation between we see in imaging findings and pain is not always there. So a lot of people have crappy looking X-rays and are just fine, and vice versa also holds true. But I guess what I was inquiring about is if you have a patient coming to you who works a job that requires them to bend and twist and rotate a lot throughout their day, manual labor, so on and so forth. And they complain of back pain. And when you ask them why they think they have it, they say my job really makes my back sore. Do you then tell that patient? Well, I can't believe that to be true because the evidence shows that just because even if they've been doing the job for like say 5 years, say they've had that job for 5 years and they're coming to see you, and their back pain started 6 months ago. I guess the argument, which we see clinically a lot, people have been doing the same thing for many years, and all of a sudden their back gets sore, and they say, it's because of my job. It's because of something I've been doing. It's just overuse and wear and tear.
Yeah, because that's what they've been taught, and so they've been set up an expectation. It might be a factor, but so often it's not a factor. Load, like there's a study by Conan and Kingma and Jap Van Dien, because they did show that people with higher occupational loads on the spine, when they measured it, had slightly greater low back pain. But flexion wasn't an independent risk factor. It's just load itself. But it's all interrelated. And we can never, with one person in front of you, you can never say for sure because it's also their genetics, their past history. There's so much of an interaction there. So I would say to those people, you've been doing it for 10 years and you haven't had pain. Nothing has really changed. Let's look at everything else that's going on in your life that changed your sensitivity. So somehow, like, you've gotten stronger and you've adapted, and now you're having low back pain. And low back pain is really common and really normal, and 80 to 90% of people that get it. We don't necessarily have to blame it on what you're doing at work, because I'm sure you have lots of coworkers who are doing the same things and they don't have pain. So we can desensitize this. Let's find all of the other sensitivity drivers. And maybe it's changing how they lift for a short period of time, just to break the habits, so to speak, try another job, but then they can ease back into it, just like you would do with an athlete.
Right? Go ahead.
Runners, an athlete's a really good example. I give it to the patient. You have a runner, they can run 100 kilometers per week. They've been doing that for 10 years. Then they take a break and they ease back up to 100 or say 80. And now they have pain again. And they think, oh my gosh, it's because I'm running 80 kilometers. I can never run 100 again. And then you start teasing out what's going on. And they've added other training in their life. They have other stressors. They have a new job. There's stress at home. And you say it's a multitude of stressors on the body. Like, physical load is not the only load we have to adapt to. It's all of these other loads, right? And then they reach their sensitivity threshold, and then they have pain. So we can change all of these, which is so fantastic. We don't just have to stay in the physical realm.
So this perfectly leads into my next question then, because it's basically on the same tangent. When I took your course and then also online, I see that many people ask you how you best integrate the pain science stuff, like you just said, finding the other factors in their lives that are contributing to their pain for that run or example you gave. And how to integrate those findings, integrate pain science, with a patient who is seeking you out because they have been told or believe you have the ability to help them with the intervention, being manual therapy, exercise, acupuncture, whatever. How do you make patients who want passive therapies to become adherent to an exercise program when all they want is the quick fix? So, for example, for that runner who you just mentioned who was running 100 Ks and they went down to 80 K and they all of a sudden they injured themselves and they coming to see you and they're like, there's something wrong with me, fix me, or like figure out why I have whatever pain they have. What do you do clinically on a kind of a real scenario basis to help that patient realize that it's not what I do that helps you, it's what you do that helps you?
Yeah. Well, if the pain science approach is actually an optimistic, positive approach, because one of the fundamentals of pain science is you have the ability to adapt, and that pain is more about sensitivity than injury. right? Those two concepts are huge that I want to get across some way to them. So I don't go and read Explain Pain to them and poems by David Butler or
No.
anything like that. We don't need all of that right away. You might want to do that slowly over time. You just choose a few small positive messages like that. And then you figure out a way that makes them realize that, like something about them, something in their past, where they sort of they get the notion that, my pain does flare up for other reasons. It's not me falling apart. So that's why I use words like you confront them with their strength. You find something in their past where they're really good at and they can have all this load on their body. And you say, look, that doesn't hurt. How damaged can you be? You're going to get out of pain because we're going to keep you running. You don't need to be fixed. I hate the idea that people need precursors to run. You have to earn the right to run or to do the sport or to rock climb. No, you do. You just start doing it. It's graded exposure. You start loading it and they adapt. Like, that is powerful. And then they get the message that they have the control. You might do some manual therapy or whatever you do to help facilitate it. But I do manual therapy to show that they're plastic, that their symptoms can be changed. And as soon as you can show them that their symptoms can be changed, either with your hands or by going through their past, then they get the idea that there's a potential, right? If it felt better last week for a few days, then there's no reason we can't build on that. They didn't miraculously get hurt and then re-injure themselves again.
Yeah, I use that all the time. If people even say if they had a good day or their pain was better for a day, it's saying that your pain is not something that you're solidified to have the rest of your life. We had to figure out those ways that modify it so you have more good days. And I guess that builds on one of the sayings a lot of people know you for, saying calm shit down and load shit up, or build shit up.
Build shit back up.
Back up, sorry.
Pretty classy.
So simplicity at its best. When you calm things down, you don't just mean with manual therapy. You mean using your words to basically
use my words like a 2-year-old. Use your words. No. I use my words. Yeah. That's what's great. I mean, those big blanket statements are kind of meaningless because it's just a framework. But you could add 10 different things to calm stuff down, right? But just that idea. Let's desensitize it. And once you start doing that, then you can start building things up. And I use the word meaningful task or global activity as well, where, just telling someone, okay, what are you missing in your life? What do you really want to do? Okay, well, let's start doing that. And that's building them back up as well and then you give them permission. That starts calming things down. Like, I'll do a history over an hour and I'm talking and interacting. And often, people will report that they feel better right there. I've done nothing, quote unquote, with my hands, but give them permission, to start, resuming their life again.
Yeah, and many times in clinic, I'll just take a thorough history and I'll explain to them like the robustness of the body, that all we have to do is get you moving in pain-free way. And once patients feel that optimism, especially those that have had a condition for a while, and a lot of people, I like patients that have been to other practitioners before me. If someone says they've been to this physio, this car, this massage therapist, and they haven't gotten better, I like that because it gives me an insight as to what they think helps them and what doesn't. So if they know, something to be said for patient preference. If they think that if they now realize that modalities won't do anything for them, like all they do is throw an ultrasound on my back or an IFC on my back, doesn't do anything for me. I know right off the bat this person is not someone who's going to relish the fact of putting a hot pack on their spine and then saying, you're better. That's already half the battle right there.
If you can look at it like this, sort of the orthopaedic division where what they're doing is they're looking for faults and components of the integrated system model, right? You're looking for joint faults. You're looking for what's wrong with them. You can flip that on your head where your exam, you're looking for what's right with them, right? That turns it around to a positive, ruling out red flags, ruling out tissue damage, showing them their strengths, showing them their range of motion, showing them how great things are. And that starts to build hope right there. And then you can build with that. So, flip the script there on the exam and find strength, not faults.
And I agree 100%. I don't think telling someone they have a rotated pelvis or a stuck segmental vertebrae is doing them any favors. they may. I think this is just my own personal opinion. You can disagree if you'd like, but I think a lot of therapists use those diagnosis or structural diagnosis because this actually leads into my next question, but it leads into the ability for the patient to think that this therapist has a specialized skill set or knowledge that no one else has or very few others have. So they feel they're in good hands if their therapist says, "Ooh, your right pelvis is anteriorly tilted," or your L4 is not moving on your L5. The patient may then feel like this therapist is taking care of me because they understand how my body moves and what's wrong with it, and therefore they have the capacity or the knowledge to fix it.
Yeah.
I think the hard thing, probably one of the hardest things of being honest, clinically to integrate the pain science model, is getting away from that, because I think many clinicians worry because they feel that what separates us from, say, a personal trainer or a kinesiologist is our ability to use our hands to assess and treat pain. I think the thought is that if we as a profession don't utilize those kinds of modalities, like our hands-on therapies, we are essentially rendering ourselves to education, exercise alone as the full scope of our treatment options. I think education and specific exercises are extremely important, but a lot of clinicians, in especially the private sector, if I'm being completely frank and honest, need to find a way or something that makes the patient feel like the person I'm seeing has that specialized body of knowledge that can help me. And that's a hard thing to move away from, I think.
Yeah.
Do you see that as being a problem with the people in your courses, for example? Do people often argue with you or question you as
No,
how am
no.
I going to...
I think they know all that. They're a little bit disillusioned with a lot of the things that are said in manual therapy, and they're tired of it. So they want to still use their skills. They just want to use it in a different package. And so that's what I try to help facilitate. You don't have to throw out what you do with your hands or your exercises. It's just fitting it in a different framework. And it's like it's a gateway drug to pain science is the idea behind my course. Like, no one is sitting down and just talking about pain with people. I mean, that doesn't have huge effect sizes. You have to do everything. That's why cognitive functional therapy is such a strong model. They do it all.
Cognitive functional therapy?
Yeah, Peter O'Sullivan's work, but I mean, he doesn't want his name, and his name is attached to it, but it's a whole group of researchers, and that's what they do. And I consider my course a cognitive functional therapy course, where you talk about people's cognitions and beliefs and what's going on with their pain. You look at the multidimensional drivers of pain. You still put your hands on. You change biomechanics sometimes. Like you're going after everything. Because biomechanics still matters. It's just figuring out when.
Okay. Yep, fair enough. And not just labeling everything as biomechanical fault. Last couple questions I have. So, again, going back to Dr. McGill's work, much of it has demonstrated, his work has demonstrated, an increased risk of, say, disc herniation with repetitive loaded flexion of the spine. Do you see a time or is there ever a time you see training lumbar flexion versus mitral spine as being safe or needed?
Yeah, so I mean, the disc herniation model was done at low loads of compression. That's what was so neat about their research. It was repeated flexion with low loads. Like, they were one of the few people to show how a disc can herniate. I mean, it was done in a biomechanical model in a cadaver model, but it shows a mechanism of injury. Because if you just compress the spine and load it really, really heavy, it's not the disc that fails; it's the end plate.
Right.
There's a paper by Adherence where if you pressurize the disc really, really fast, then maybe you get some herniations too under really, really heavy load. So I think heavy load with some flexion. This is the study by Adherence, then you might have an increased disc herniation. Otherwise, if it's a neutral, you're just going to cause end plate loading. And then Stu showed with Jack Callahan in 2001 in the cadaver model that the disc can delaminate with repeated flexion extension cycles. What's interesting, they only went to 35% of end range. So it wasn't even a lot of flexion extension. And they showed that created herniation. So sorry,
So with
what
that
was your
said,
question?
so with that said, then that's good. That's good background research information. With that said, then do you ever deem there to be a safe period or a need to train someone with in loaded flexion, depending on the tasks they want to achieve in their daily life?
So with that said, this is what's difficult for me because I believe that research is good. I have trouble extrapolating that research to daily life. So that model says if you do repeated small flexions, you can get a disc herniation. But life is repeated small flexions. Sport is repeated small flexions. When you do a squat or a kettlebell swing, you're flexing your spine 26 to 40 degrees. That's more than 50% of the full range. When you do a golf swing, it's like 40 to 50% of flexion. When you're rowing, when you're cycling, when you're cross-country skiing, these are highly repetitive, and yet we don't have this massive disability epidemic due to disc herniation. Disc herniation might be 5 patients a year. It's 2 to 5% of the problem. So I'm confronted with these two, this discordancy with good research showing that's a problem with the fact that everyone has to flex. So I've chosen a side here of the fence, and I say low loaded flexion, because flexion is normal and has to happen. I don't want to worry about it. I think everyone should flex without fear, unless it hurts, and then maybe we stop doing it for a little bit, just like anything else. And then under high load conditions, where I think we can listen to Stu and we can listen to coaching wisdom from weight training for years, where they train a neutral spine. There doesn't seem really to be any benefit from training into deep flexion under heavy loads. So it seems the safest bet is to try to maintain neutral there, even though maintaining neutral is impossible. There's still going to be some flexion. Mm-hmm. So the idea of can you train to tolerate that, that leads us to the next big question. I'm sure if you do repeated heavy flexions, your muscles will get stronger, and so will the joints. But maybe the disc won't, because tissues adapt at different rates. So there's still a potential there, because we don't have animal models to really study this stuff. We're in the dark here completely. We don't know how the disc responds to repeated heavy loading in flexion. So without there being a very, very clear benefit to say that you should train it in heavy flexion, why would you do it? Can you sell it for performance? I don't think so. No heavy lifting task, except heavy deadlifts. I mean, they do it, but that's just to get it done. They don't train that way. The clean and jerk, they try to maintain neutral. So under heavy loads, I would say no. Under light loads, flex away.
Okay.
If it hurts, stop.
For the MMA fighter who comes in, who does a lot of grappling, which is repetitive flexion, and they want training, or they want to be trained. Is it then fair to say that the demands of this person's sport require repetitive flexion in all different ranges? This is something we're going to train.
Yeah, but they're not too heavy, right? That's doing sit-ups and heavy loaded sit-ups. That's not super duper heavy. That's not like lifting 500 pounds during a deadlift.
So in a very practical...
I would say they're fine until they're not, and we have no idea. And then the other argument there is if it hurts, then avoid it. Mm-hmm. Like gymnasts been doing curl-ups. You have to do some of that. That's part of doing a back tuck is spine flexion. It's part of doing a front tuck. Okay. Yeah. So train both.
Okay. So I guess when I was talking to Stu McGill last week, he was talking about training flexion moment, like training the actual moment, but not the load, like not actually going into flexion. He mentioned doing things like basic things like a stir the pot, or even plank rolls, those kinds of things.
You know what? If a few other papers came out, like those are great too, because you don't have to be specific. There is a huge carryover from training isometrically and just general strength training. So that strength will carry over to a flexion movement. So
and that's what I was getting at.
I think that's Stu's strongest argument. You could say that person gets enough flexion during their sport-specific training, so you train it in neutral all the other times. Like there's nothing wrong with that too. That's really, really strong as well. And so to say when I come out and say, oh, train flexion, that's kind of up to the strength and conditioning coaches. That's where that argument might be best resolved. who gets better results. And they've done that with one paper on stiffness, Ben Lee, I think, but that would be the next step. Do you actually need to train a lot of flexion to get an improvement in sport performance?
And that
or
was
could
where
you
I was
just
coming
train
from with my
isometrically?
question.
So
Like
if you can
did
train
this
isometrically and performance is the same, and we can argue that potentially might be safer, then I'm willing to jump the fence here and switch sides on some of those.
Okay.
It's just there's a lot of gray area here. I'm comfortable with that.
Yeah, I know. We know how comfortable you are with uncertainty. You're all right.
No.
I guess that's where I'm coming from, because I treat athletes, but I also treat, like a lot of people listening to this, the everyday person with, may not be as physically active as they would like, and who are sedentary, maybe a little bit overweight, and they have back pain. I personally prefer to treat neutral spine isometrically. I believe in doing like things like stir the pots, planks, hip thrusts, things that kind of prevent excessive motion both into flexion and extension in the back. Just as a general rule, I find are tolerated a little better by most people. I think it decreases that threat response too by not going into those end ranges that they deem to be less safe.
Yeah.
And even though it may not be, and then slowly building back up, that's why I like, for example, like the McKenzie approach. They're taught like, I'm going to bastardize it, but for the most part, they say, well, do repeated extensions, which I know is not the whole thing of McKenzie by any means, but and then over time, once that pain subsides down their leg and to their back, then one of the discharge criteria is, can they bend forward again? Can they flex forward? And I take that as a great thing, because if you teach someone to train in neutral spine by doing the exercises we just mentioned, it's not enough to say, okay, best of luck, you're out of pain now. I think you have to teach that person that the motion that they're scared of, in this case being flexion, is safe to do.
Yeah, it's just graded exposure. That's it.
Mm-hmm.
It's that simple.
Yeah. I guess
you start with what they have. You avoid the trigger. You build them up, give them confidence in their spine, and then slowly start exposing to the offending task.
Fair enough.
That's what we do with everything. That's what you do with sport. That's what you do with rehab.
Yeah, you're not starting.
You can't avoid it forever.
Yeah, like I say to patients, we're not going to start playing basketball by shooting 3-pointers. You're going to start by learning how to do a layup, and then we'll work backwards from there. My last question is a little off topic from this, but it just goes to the I guess the modality empire of it all in the rehab world. I wanted to get your opinion and your thoughts on the influx of techniques such as dry needling, electroacupuncture, and other muscle energy type technique approaches, NKTs, one pops into my head, as being systems that people use or tools people have in their proverbial toolbox that they use to get people feeling better. I know you don't personally use acupuncture in your practice, which is fine, but I'm wondering what your thoughts on using those kinds of modalities for patients who are in pain.
I did the training in the McMaster electromedical acupuncture course.
Oh, did you?
So I know a little bit about it. Yeah. I did it in physio school there. I was busy. So I can speak on it, and I did it for maybe a year if people would ask for it. And that to me was the thing. If they asked for it, and I was doing everything else, and I didn't feel like it was inhibiting, what they thought of their pain, then I have difficulty disparaging it. Acupuncture gets knocked a lot, and mainly because we have really good shams for it. So we have really good, when we test it, they might say, well, there's no specific effect. But both, the sham needle and the real needle make some small changes. So I can't ignore that. And I think if we tested all of our exercise programs and manual therapy and we had a true sham for all of those, I think the same thing would happen. So I have trouble throwing people under the bus that do acupuncture. The bigger issue is when you say that it has to be done and you're fixing this and all of that. But if you use it just as a desensitizer in that calm shit down model, then I'm kind of okay with it, because And if you don't just leave it there and you do all the other good things that we know we can do, then it just seems to fit into the whole. So I just have difficulty being mean to those guys.
I know.
I don't want to be a hypocrite, because I think if you put my favorite, we all do touch of possible. If you put, I mean, there's never been a good sham for explained pain or therapeutic neuroscience education. Is it the knowledge, or is it the fact that someone's listening to you and letting you tell your story and all of these things? So, if we really controlled for all our interventions and good studies, they might not show up that well.
Yeah. One thing I found, I guess, going back to what you just said, is I want to find a way to say this a little more objectively, but I find clinically, if I, in taking a history of a new patient, ask them about like their family, their kids, their wife, their husband, whoever, and I jot some notes down about them, like their son has a hockey game next week, or they're going on a trip in a month, wherever they're going. And if I remind them of that when I see them in a week or so, if I'm like, oh, how's your son's hockey game? Did he win? Just simply saying those things and making patient realize that I'm actually listening to them and I have an interest in not just their pain, but who they are, I find dramatically helps my outcomes.
Yeah.
And I remember initially, I messaged you a little while ago because I was having like an internal crisis in terms of I do dry needling on occasion with patients, and some people find it very effective. And I had a subset of patients who were strictly, even though I would do everything else, the needling was a 5-minute intervention out of a 30-minute session, they would still attribute the success of their treatment or the pain relief to the needling. And I was like, how am I gonna get out of this? Because I'm like, I don't want them to think it's a needle that's making them feel better. Can it help? I'm sure it can, because I'm seeing it. But is it me talking to them about their lives and kind of being a sympathetic ear? Is that having something to do with it? Being optimistic and showing how robust they are? Has that something to do with it? And I guess I was getting confused or trying to figure out how to get patients to attribute the success of their outcomes not to an intervention, but the whole kind of to them. Do you get what I'm saying here?
Yeah, of course.
I know it's a little convoluted. Yeah. And I guess, do you have any insight as to how we?
If someone comes in and they want to be needled for a bit, sometimes you have to acquiesce, because if you say no, then you lose that opportunity to talk about all of the other drivers of pain. Right? Now you can needle and you can start talking to them about everything else, right? So if you put them first rather than your own beliefs, same thing. If someone comes in and they want lots of deep soft tissue work, if you just say no, boom, you lose them and they go somewhere else. But if you say yes for a bit and then you slowly stop doing that stuff because now they buy into this other model where they can help themselves, then you've helped someone because our ego didn't get in the way. Right?
I think
does that make sense? So by you saying, I'm going to do it for a bit, but let's do all these other things as well.
I think
that there's that shift, that maybe you make that shift so that they start believing that there's something else going on. That's how you can use that stuff.
I think giving people a little bit of I think you're absolutely right. I think giving people a little bit of what they want and mixing in a little bit what they need goes a long way at getting that buy-in. It's just I think in our profession we're so hard on ourselves sometimes. Do you think that's the case? I go online and people are bashing. Someone's like, "Oh, you're using ART, you're an idiot. You're using acupuncture, you're an idiot." And I'm only in this profession, so I don't really know a lot about others. But I can't see other professions in the healthcare world being so hard on each other over what we choose to do, as long as we can frame it in a positive way. And I think someone takes an ART course or takes an acupuncture course or whatever the case may be, and they implement that into their practice as part of a total treatment program, I don't think that's a problem. But there's a lot of people who go online and read social media stuff on Facebook websites, on physiotherapy, so on and so forth websites, and they then realize that, oh my God, I'm crippling my patients. I'm making them feel like they're obsolete, and then they freak out that they're I'm speaking from experience too. I'm much better now than I was when I was a new grad 5 years ago. But I think you'll remember I was like freaked out. I was like, what am I supposed to do in clinical practice if all the stuff that I was trained in physio school was pretty much wrong? And I think a lot of new grads right now are really going through that. I teach at U of T in the physio department, and the new grads, like the ones that are just coming out, are shell shocked, not by patients so much, but when they go home, they Google, how to treat back pain or tennis elbow or whatever, and then they see these such confounding kind of philosophies. It really leaves the clinician to scratch their head a little bit. So I like the fact that you said just now that you are okay with clinicians using whatever modality they choose, as long as they factor in a more of a patient-centered approach using like the biopsychosocial model.
Yeah, and then they might find over time that they don't have to use that stuff. Yeah. I've certainly found that less and less.
Yeah.
And so you'll be lost if you throw away what you're comfortable with. Then you'll just be naked and useless for a little bit.
Yeah.
You can ease into getting naked and effective.
So those are all the questions I had for today. I think we did a lot. We just covered a lot of good discussion. I think clinicians are going to leave this podcast with an understanding of what you think and how to best incorporate some of the pain science into their practice. But if they want to learn more about what you do and how you teach and what courses you provide, how can they find you online?
My website's just greglehman.ca. I don't have any courses planned for Ontario here, but I think maybe Toronto in the fall. I want to do one in November. After I think I'm going to run a marathon, and the next week teach a course. But so my schedule's online. I'm pretty booked till December, but I usually have to get on a plane. So I would love just to take the streetcar to teach a course.
Yeah, I'm sure you did the one.
I just need a host.
You just did the one in Toronto, right?
Yeah, a long time ago. Yeah.
Okay.
Probably done 30 since last March there.
Yeah, that was the first one you did, right, in Toronto with me?
I'm big in Scandinavia.
Yeah, you're all over that place.
My wife's like, you're like David Hasselhoff in Germany. Like I can't. Oh, I did one in Hamilton last year. That was good.
That was good.
But I've been to Oslo like 3 times. It's crazy.
That's great. You're internationally known, my friend. All right. So on that note, we're going to end things. And if people have any further questions, they can either contact myself, and I will put them in touch with Greg, and we'll go from there.
Oh yeah, social media too. That's always like a good way to talk. On Facebook and Twitter.
Okay. What's your Twitter handle?
I try to respond to emails too.
Okay. And how do people find you on Twitter, Greg?
Just my name.
Just Greg Lehman? Okay.
No numbers.
Okay. So with that said, I want to thank Greg Lehman for his time today, and I hope you all enjoyed the podcast. Until next time, thank you very much.
Yeah.